Congenital muscular torticollis is a postural deformity detected at birth or shortly after. It is primarily a result of the shortening and fibrosis of the neck muscles, specifically the sternocleidomastoid muscles. Other causes include intrauterine position, lack of space in uterus, traumatic birth, multiple births, low amniotic fluid, tumor in the sternocleidomastoid muscle, tightness and thickening of the muscle, and other asymmetry neck problems due to eye problems, congenital absence of cervical muscles, low muscle tone. Also, general delayed development, positionally induced, and environmental factors. It is often seen clinically as a child's head tilting to one side due to the shortening of the sternocleidomastoid muscles. The diagnosis is commonly made by 2 to 3 months when abnormal head posture, restricted cervical range of motion, or plagiocephaly is identified during a well baby visit to the pediatrician. Plagiocephaly is commonly reported as a coexisting impairment in more than 90% of children with congenital muscular torticollis. Plagiocephaly, or flat head syndrome, is a condition where the head is asymmetrical and flattened on one side more than the other. It is also common that one side of the forehead pushes out further than the other, and that there is a shifting in jaw and ear position, and one eye appears larger than the other. Although commonly considered a cosmetic issue, the primary concern is not cosmetic, but in the function of the child's ability to chew and speak, and in various visual issues such as tracking and awareness to surroundings. Also, children with plagiocephaly could be at risk to decreased motor development, which can later affect their cognitive function. Plagiocephaly can also be seen without involvement of the sternocleidomastoid muscle. Similarly to congenital muscular torticollis, plagiocephaly can be prenatal due to restricted uterine environment, lack of amniotic fluid, multiple births, or increased abdominal or uterine muscle tone. Premature infants are also at a higher risk of developing plagiocephaly because cranial bones become stronger and harder in the last 10 weeks of pregnancy. They also experience extended time in the neonatal intensive care unit with their heads in a fixed position due to respirators and other life-saving devices. There has been a large increase in babies with positional plagiocephaly due to babies sleeping on their backs. The National Institute of Child Health and Human Development created a campaign called Safe to Sleep, which promoted babies sleeping on their backs in order to prevent sudden infant death syndrome. Added later was the Back to Sleep, Tummy to Play campaign. However, many infants do not receive tummy time, spending too much time in car seats, swings, and infant carriers. Tummy time is when a child is encouraged through forced prone position to lift their own head during awake times. Both congenital muscular torticollis and plagiocephaly are treated very similarly. Parent education is one of the most important aspects of intervention, especially on positioning to promote lengthening of the involved side. Changing the position the child sleeps in is also very important, as well as alternating positions throughout the day. An emphasis on stretching and increasing range of motion is the main focus of a child with congenital muscular torticollis due to the involvement of the shortening of the sternocleidomastoid muscle. Manual stretching is the most common form of treatment. Stretching can be carried out through holding, carrying, and playing with the child in postures and positions that achieve the desired active and passive movements. Specifically, neurodevelopmental techniques are commonly used to promote active and passive range of motion. These include side bending, also known as ear to shoulder stretching. This is where a child's neck is passively stretched to the unaffected side while the therapist presses down on the affected side's shoulder. Rotation or chin to shoulder stretching is also common. This is where the therapist passively brings the child's chin to the unaffected shoulder and holds for 10 to 15 seconds. Also common is the shoulder depression, which can be done in different positions in order to open up the joint space. Due to the involvement of the cervical muscles, motor development may be delayed in children with both congenital muscular torticollis and plagiocephaly, due to the lack of acquisition of the non-affected side. Through purposeful play designed to integrate specific movements and behaviors, a therapist will promote looking away from the affected side and increased motor development. Various environmental adaptations can be done in order to promote development and integration of the affected side. For example, positioning the child in the crib or changing table so that they are encouraged to look away from restriction, as well as positioning toys to encourage this. While bottle feeding or breastfeeding, positioning the child to stretch to the restricted side as well as alternating from one side to another regularly while feeding. Specific equipment can be purchased to provide head and neck support when a child is placed in their car seat, stroller, and when in their crib. In severe cases, cranial bands or shaping helmets, as they are commonly known as, are used to encourage the skull to fill out in the flattened areas and encourage jaw realignment. Length of time a cranial band is typically worn depends on age and severity and growth. Typically, a child from 4 to 6 months old wears it for 6 to 12 weeks, a child from 6 to 10 months old for 10 to 16 weeks, and a child from 10 to 18 months will wear it for 14 to 16 weeks. The cranial bands are incredibly lightweight, and an infant is usually not aware that it is on their head. As you can see, the results from cranial bands are incredible. Another technique used is kinesiotaping. However, it is a very new area of practice and has limited research. It is mostly used for congenital muscular torticollis as a way to help promote the stretching of the sternocleidoid mastoid muscle. Through early identification before the age of 1, a child will be able to reach appropriate developmental milestones through the application of occupational therapy interventions, adaptations, and techniques that have been previously mentioned. However, if left untreated, many children suffer from many of the following associated problems: open mouth posture, tongue pulled to one side or another, suck and swallow are affected, permanent shortening of neck muscles, permanent facial asymmetry, feeding issues, decreased head control, difficulty walking, unequal weight bearing, decreased environmental awareness, decreased coordination, and many others. If you or someone you love are concerned their child may have congenital muscular torticollis or plagiocephaly, speak to your pediatrician immediately. There are also many locations that specialize in the treatment of both congenital muscular torticollis and plagiocephaly that you can contact after seeing your child's pediatrician.